My name is Ashraf Alzaabi. I'm the president of the Emirates Thoracic Society. It's a great pleasure to be with you today and for a regular Emirates Thoracic Society meeting. And it's our honor to host two distinguished speakers of our colleagues. We have the first speaker, Dr. Mohsen Nasir from Cleveland Clinic, Abu Dhabi. Dr. Mohsen Nasir today will give the first talk on severe allergic asthma phenotyping from bench to bedside. Dr. Mohsen, the floor is yours.
Thank you, Dr. Ashraf. Let me just thank you everybody for coming. It's unfortunate that we still have to kind of do these virtually. Hope everybody is safe and sound during this pandemic, and inshallah soon we can kind of get back to doing these in person. So given the topic, severe asthma phenotypes from bench to bedside, and then in kind of, researching this topic, I feel like maybe we actually need to go back to the bench because we may not be where we want at this point in time. So what we're going to do today, briefly define severe asthma, just in case there's some people in the audience that aren't taking care of asthmatics or maybe the severe asthma people. And then we're going to look at the following definitions. What's a phenotype? What's an endotype, and what's a biomarker? And it's going to be important to define these terms because throughout the rest of the presentation, we're going to be talking about them and specifically how they pertain to severe asthma. And then we're going to look at one study showing that how biomarkers may actually predict response to therapy in severe asthma. And we need more studies like this to kind of help us guide us into the future. And then we'll do a quick wrap up. So again, briefly, what is asthma? This is a chronic inflammatory disorder associated with hyperresponsiveness of the airways. And patients have symptoms of recurrent wheezing, coughing, chest tightness, and difficulty breathing, especially at night and early in the morning. Again, airflow limitation occurs as a result of obstruction when exposed to triggers. And triggers can be anything from cold air, infections, smoke, strong smells, allergens, exercise. These can all kind of trigger asthma. These episodes are usually associated with widespread, but again, variable airflow obstruction that's often reversible. And though, most patients we can kind of treat for exacerbations, patients with severe asthma, these can be life-threatening, and there's a significant burden with them. So asthma, again, it's a common disease worldwide with increasing prevalence. Not only is this good for job security, but really it's something that we've been seeing more and more throughout the world, along with other kind of atopic or allergic diseases. We've seen more food allergy, rhinitis, atopic derm, eosinophilic esophagitis. So these kind of allergic diseases have been increasing throughout the world. Just so everybody's on the same page, these are from the GINA guidelines, and we classify asthma from intermittent, mild, moderate, and severe persistent. We're going to be talking here about the severe persistent asthmatic. So these patients are having, daily symptoms, frequent exacerbations, frequent nocturnal symptoms, and they have marked reduction in lung function. So treatment with GINA steps 4 or 5 for the previous year, and or treatment with systemic steroids for at least half of the year. And that's how the ERS and the ATS define severe asthma. Again, most of these patients are going to be on a high dose ICS LABA, oftentimes maybe a LAMA medicine like Singulair. And you need a lot of these medications to prevent loss of control of their asthma. You need to exclude other diagnoses. And then again, we have to control for other factors and comorbid conditions. Patients have to be compliant with therapy. Different prevalence shows that severe asthma may be 5%, 10% of all asthmatics. But again, despite them being a small minority of asthmatic patients, they account for the vast majority of healthcare costs associated with asthma. And again here, GINA guidelines, we're looking at multiple inhalers, oral medications, Theophylline, Singulair, biologic agents to hopefully stem the use of chronic long-term oral corticosteroids. Again, the burden of severe asthma is high. Patients with mild or moderate asthma, as long as they're compliant, we can take care of them, but severe asthma is difficult to take care of. Many patients require frequent, recurrent, chronic use of systemic corticosteroids, and they have to be compliant. And again, their asthma profoundly impacts their lives. Just one quick study looking at how bad this disease can be. This is from 19 hospitals in Spain and South America, looking at hospitalization outcomes in patients with asthma, intermittent, mild, moderate, and severe asthma, about 2,600 patients. And as you can see here, patients with severe asthma on admission in the hospitalization had a worse pH, worse lung function, were in the hospital longer, more likely to be intubated on mechanical ventilation, and have severe outcomes such as death. So again, this is a tough disease to take care of. And so where are we now? So asthma phenotypes. Phenotypes has kind of been a buzzword in the asthma literature for maybe the last 5 or 10 years. You've had, different cohorts of patients like the SARP program trying to come up with individualized phenotypes for how we can take care of asthma. So let's talk a little bit about phenotypes and what they are. So phenotypes in asthma. One of my mentors in fellowship told me that asthma it's just not a good term. This should be asthmas, right? So you have a kid with intermittent asthma versus an adult with severe persistent eosinophilic asthma. These are two completely different diseases. You can have patients with two arrhythmias. You don't say they have an arrhythmia. They can have, VTAC, VFib, they can have AFib, even cancer. So asthmas is probably better than just the word asthma. And how do we break it down? Phenotypes. Phenotypes are the observable characteristics of a disease of an individual. So phenotype, think physical. This is what we observe in a patient. Endotype, these are biological mechanisms internally that cause the observed properties of a phenotype. And why is this important? Because to properly assess a disease's phenotype or endotype is essential, especially when we're going to start talking about biologic or immunomodulatory therapeutics. And this is going to be useful in managing severe asthma. How about the term biomarkers? So the NIH defines a biomarker as a characteristic that is objectively measured and evaluated as an indicator of a normal biological process, pathogenic process, or a pharmacological response to a therapeutic intervention. Biomarkers, again, these are objectively measurable characteristics of a disease, which we then use to distinguish asthma phenotypes and endotypes. And biomarkers obviously are not unique to asthma. They're used in multiple other diseases, in heart disease, kidney disease, strokes, rheumatological diseases, infections, etc. So, we have biomarkers that may be unique to asthma, but the biomarkers, we have them in multiple other diseases. So this comes from a really good review that Monica Kraft published 2 years ago in the Annals of Allergy. And this is, one way of breaking down phenotypes of asthma. And you can see here kind of your kids with early onset allergic asthma, early onset obesity exacerbated, AERD, ABPA, severe late onset hypereosinophilic asthma, exacerbation prone, and then kind of our non-T2 asthmas, your neutrophilic, obesity-induced, and polygranulocytic. So these are some phenotypes of asthma. Now looking over here, looking at the biomarkers, we have great biomarkers. They're relatively cheap. They're easy to use. They're reproducible. Unfortunately, they're not really pathognomonic for any individual asthma. So you can see here, for example, allergen-specific IgE. We can see it in early onset asthma. We can also see it in ABPA, eosinophils, again, early onset asthma. We see it in APPA. We can see it in AERD as well, and exacerbation prone asthma. So we have biomarkers, but there are a lot of overlap amongst the phenotypes, which can make using them a little bit difficult. Again, biomarkers are helpful, but unfortunately at this time, they're not pathognomonic for an individual phenotype, maybe except for AERD. So for example, again, IgE, we can see an early onset allergic asthma or late onset hypereosinophilic asthma can also have eosinophils. However, we do see IgE in the late onset eosinophilics, and we do see eosinophils in the younger allergic asthmatics as well. There's two real ways to divide phenotypes if you look in the literature in multiple reviews. One way is late adult onset versus early childhood onset phenotypes. And you can see here for kind of the late adult, you have allergic, severe, occupational, AERD, eosinophilic, but there are a lot of overlaps between them. And then again, same with the early childhood onset phenotypes. You have allergic, within the allergic, you can have eosinophilic, exacerbation prone, and the severe. So again, I don't really like using this early versus late onset. I kind of think of these when approaching patients as T2 high versus T2 low. And again, really Th2 driven inflammation, I think, defines the major subphenotypes of asthma. And T2 high asthma, this tends to be more severe. They have IgE, they have eosinophilia, and it tends to present earlier on, maybe in childhood or in the teens, but it can persist into adulthood. And they tend to be responsive to inhibitors of T2 inflammation. Versus T2 low asthma, in general, tends to be less severe. They don't really have eosinophils, more so in adults. And again, it can be linked to obesity, neutrophilia, smoking, and they don't really respond that well to corticosteroids. So what biomarkers are used again in severe asthma? We talked about some of them. This again comes from the Monica Kraft study. So you have a patient, moderate or severe persistent asthma that you're seeing in your clinic. This is what you do. You assess for specific IgE with either serum-specific IgE testing or skin prick testing, get a total serum IgE and eosinophils, and then pheno, if available, you want to measure the fractional exhaled nitric oxide. If patients have clinically relevant allergen-specific IgE, if they meet the criteria for ABPA, then you can diagnose them with having ABPA. If not, do they have early onset or other atopic comorbidities? Do they have allergic rhinitis, atopic dermatitis, etc.? If so, you can kind of call them early onset allergic asthma. If not, you're going to go down the eosinophil pathway. Do they have eosinophils in their blood? Some cutoffs are 150, most cutoffs are 300, or evidence of eosinophils in their sputum, 2 to 3%, or tissues with the biopsy. If so, are they sensitive to COX-1 inhibitors? If so, they have AERD. If not, they have late onset eosinophilic asthma, no IgE, no eosinophils. Then we're looking at the T2 low asthmatics. So let's look at some of the individual biomarkers, starting with IgE. Again, IgE, we know it plays an integral role in asthmatics. Studies have shown that over half of asthmatics have allergen-specific IgE, and in the TETR study, they found that almost all patients with severe or difficult to treat asthma who were skin test positive. We do know that the higher the total serum IgE levels correlates with more severe asthma. And then in children, sensitization to certain aeroallergens such as cats or house dust mites independently is a risk factor for more severe asthma. Now, obviously, if you're not atopic, that doesn't necessarily rule out asthma. And then we also know that immunotherapy, either sublingual or subcutaneous, is effective in inducing immunological tolerance and desensitizing patients. And that also shows that allergy can play a role in asthma. And then here, again, how does IgE work really quick? Airway inflammation results from allergen sensitization. You inhale any type of perennial or seasonal allergen, pollens, grass, tree, weeds, molds, cat, dog, dust mite, pick your poison. Allergens get taken up by the dendritic cells in the airways, gets processed and then presented to a T2 cell. Th2-driven releases of our friendly cytokines IL-4, 5, and 13. This promotes the formation of specific IgE to the allergen. This IgE then binds to the Fc epsilon receptors on mast cells and basophils in the airway. Re-exposure to the allergen binds to the IgE on the mast cells. You get cross-linking, intracellular signaling, and then the release of mediators such as histamine, leukotrienes, prostaglandins. And these mediators are responsible for the symptoms that we see with airway inflammation. So that's how IgE works. The role of IgE in asthma, again, here you can see this was published in the New England Journal over 20 years ago from Ben Burrows and colleagues in Arizona. The odds ratio of developing asthma increases significantly as the serum IgE level goes up, even when you correct for age, sex, smoking, and skin testing. And interestingly, in this study, you're more likely to have asthma with a higher serum IgE level than you are to have allergic rhinitis. And allergic rhinitis, we kind of think of our classic IgE-mediated respiratory disease. And again here, IgE levels correlate with severity of asthma as well. So in this study published about 10 years ago, they looked at, kind of our inner city asthmatics in the US, so African-American, Mexican, and Puerto Rican. And what they found that for a given IgE level, the higher the total serum IgE, the more likely they were to have more severe asthma. This was also associated with poorer lung function, increased airway obstruction, higher risk of hospital admission, and greater use of ICS. And as you can see here, for example, of a cutoff of 100 of total serum IgE greater than versus less than, you had worsening lung function, FEV1, FEF25, 75 down the road. The vast majority of these were statistically significant. Now moving on to eosinophils as another biomarker that we use to phenotype our asthmatics. We know that airway eosinophilia is found in at least half of asthmatics. Eosinophilic airway inflammation increases the risk of severe exacerbations, and there's an inverse correlation between FEV1 and blood eosinophils. So the higher your blood eosinophil count is in an asthmatic, you have worsening FEV1. Now, eosinophils can also be found in the peripheral blood, airway submucosa, or airway lumen. And unfortunately, eosinophilia doesn't always correlate with tissue eosinophils. A recent meta-analysis published a couple years ago shows that there's, in terms of correlation of peripheral blood eosinophilia versus airway eosinophilia, the sensitivity is only 71% and the specificity is only 77%. So we may be missing some of our eosinophilic asthmatics unless we look within the airways. Again, most studies define blood eosinophil greater than 300 or sputum of 2 to 3% to be diagnostic of an eosinophilic disease. And again, we can use this as a predictive biomarker for response to steroids. And again, how do eosinophils work? Via the all-important IL-5 cytokine released by our Th2 helper cells. This goes to our CD34, pluripotent stem cells in the bone marrow. You get eosinophilic production. This goes then to the blood vessels, and via different, cell adhesion molecules, you get recruitment into the smooth muscle cells of the airways. Further secretion of IL-5, 4, and 13. You get muscle hypertrophy, increased airway responsiveness, goblet cell metaplasia, and that's how eosinophils, in a nutshell, work in the airways in terms of eosinophilic inflammation. Eosinophils secrete major basic protein, eosinophilic-derived neurotoxin, leukotrienes, and interleukins, as well as TNF-alpha, and these are responsible for the inflammation in the airways. And then again, looking at the higher eosinophil levels in this study showed that if blood eosinophils of greater than 400 versus less than 400, you were much more likely to have at least 2 exacerbations for asthma in the previous year if you had higher eosinophils, or 1 ED visit or hospitalization for asthma if you have higher eosinophils versus lower eosinophils. And you can see here in this study, you're more likely to have a severe exacerbation, acute respiratory event, and lower asthma control the higher your total serum eosinophil levels are. So one limitation of eosinophils, unfortunately, is that just because you find eosinophils, that doesn't necessarily mean that they're active, right? And so I kind of look at this in the esophagus. You can have esophageal eosinophilia, where you have resident eosinophils in the esophagus. That doesn't necessarily mean that you have active inflammation. Now, if you do a biopsy and you see inflammation, then you have eosinophilic esophagitis. So what we need to do is we need a better biomarker to help see if the eosinophils that we have are actually stimulated and active. And there are some biomarkers that they're looking at right now. One of them is eosinophil peroxidase. This is shown to be increased in poorly controlled asthmas. And actually, bromotyrosine is an oxidation product of eosinophil peroxidase. And this has been shown to be induced by airway challenge. And the nice thing about bromotyrosine is it actually can be measured in the urine. And high urinary levels are actually correlated with uncontrolled asthma and increased risk of asthma exacerbation in children. And it's also been shown to be used as a predictor of response to corticosteroids in asthma. Now, interestingly, urinary bromotyrosine was not induced by aspirin challenges in AERD patients. And so that may show that even though AERD patients have high levels of eosinophilia, they have chronic hypereosinophilic hyperplastic sinusitis, it may be the mast cells and the leukotrienes that are responsible for the airways inflammation is in this disease, less so the eosinophils. And we'll look at that in a little bit. So exhaled nitric oxide, I don't know how many of you are using this in your clinic, but this is something that we've established at Cleveland Clinic, and it has been helpful. It's not the magic bullet or the end all be all, but it has been helpful. What is ENO? So this is generated by nitric oxide synthesis in the airways. and it has a natural bronchodilatory and vasodilatory effect. It's a use as a clinical biomarker of airway inflammation, so kind of as a surrogate for IL-4 and IL-13. Higher levels are linked to severe early onset allergic and eosinophilic asthma. Rising levels of E&O over time have been shown to indicate potential loss of asthma control and can predict an exacerbation. Now, it's only moderately diagnostic for sputum eosinophils, about 66% sensitive. And again, we can use it to monitor response or adherence to corticosteroids, and that's where it can be helpful. So this was published from David Price and colleagues about 6 years ago. And for those of you that don't regularly use E&O in your practice, this is kind of a helpful review as to where our cutoffs are for symptom control and not symptom control, and how E&O can help us guide our treatment decision. So for example, if you get an E&O on a patient and it's low, and for adult less than 25, for a child less than 20, if they're symptomatic, you want to consider other diagnoses, or maybe consider adding a non-ICS therapy or evaluate for adherence. If they're asymptomatic, consider stepping down their ICS dose, or if they're on a low dose Flovent or a low dose, QVAR, maybe discontinuing the ICS altogether. And again, for intermediate levels and high levels, we have decisions that we could take with E&O as well. I'm not going to go through this whole slide. This study has shown when you look at the average of E&O over 2 weeks in patients stratified by asthma control, you're more likely to have better control of your asthma the lower your E&O levels are, less likely to have control the higher the E&O levels. The nice thing about this biomarker, it's simple, it's well tolerated, it's non-invasive. We can use it to try to surrogately measure inflammation in the airways. And again, we can use it to predict loss of control of asthma. One thing that's kind of new in the biomarker and phenotype of asthma world is mast cell related biomarkers. Now, mast cells are something as allergists that we're very familiar with. And I'm just going to talk briefly about them and then go over one study that was published in the New England Journal of Medicine looking at mast cell as a potential biomarker and treatment for asthma. So really this, the sine qua non or the example of mast cell related disease would be AERD. Again, this is Samter's triad, nasal polyps, asthma, and aspirin sensitivity. Now, AERD, this is a non-IgE mediated hypersensitivity reaction. It's due to a type 1 pseudo-allergy upon ingestion of COX-1 inhibitors. Patients get acute upper and lower respiratory reactions ranging anywhere from conjunctivitis, rhinitis, nasal congestion, all the way to coughing, bronchospasm, and potential respiratory failure. And it's not due to IgE, but it's due to a dysregulation of the arachidonic acid metabolism. You get overproduction of leukotrienes. This leads to bronchoconstriction, mucus secretion, and airway edema. And again, these patients tend to have marked tissue eosinophilia and do well with steroids. Now, leukotrienes are primarily produced from mast cells, and patients with AERD do not have prostaglandin E2. This is bronchoproductive. Instead, you get shunting towards prostaglandin D2, which causes airways inflammation, and you also get increase of leukotriene E4, which can be measured in the urine. Now, one way we treat these patients is to desensitize them to aspirin. This can be done in the outpatient setting. And as long as a patient takes high dose of an aspirin daily, at least 325 milligrams, they can be desensitized to aspirin. They can safely take other NSAIDs, and it can be used both for lower and upper airway protection. Now, what about mast cells? So mast cell development and survival depends upon stem cell factor and its receptor kit. Airway mast cells, stem cell factor, and kit levels have been shown to correlate with hyperresponsiveness and asthma disease severity. And recently, investigators have looked at potentially using KIT inhibitor imatinib or Gleevec to treat severe, poorly controlled asthmatics who are receiving maximal medical therapy. And they did a randomized double-blind placebo-controlled trial of 24 weeks of Gleevec versus placebo in this patient population. And their primary endpoint was the change in PC20 from a methylcholine challenge. And this is the study that was done in the New England Journal back in 2017. This is the baseline characteristic of the intention to treat population. Again, average age, kind of middle age, around the 40s, primarily female, white, age of onset of asthma, teenagers. And you can see here, FEV1, was 71, 65% predicted. Pheno kind of in that middle range, 35. High eosinophil count, relatively high total serum IgE. Most of these patients were on an ICS and a LABA, Singulair, some were on Xolair, and some patients were on chronic oral corticosteroids. So again, high medication burden in this patient population. And what they found, two things. Number one, tryptase levels decrease in the patients on imatinib. Tryptase is released when mast cells are activated. It's what we use to help diagnose anaphylaxis as well as mastocytosis. Additionally, there was a significant improvement in the PC20 in patients that received Gleevec, both at 3 months and 6 months, as opposed to placebo. So there was a non-significant improvement in asthma exacerbations over the 6 months, morning and evening peak flows, asthma control questionnaire, and reduction in airway wall thickness. There was improvement, but it did not reach statistical significance. No changes in EOS, FeNO, BAL leukotrienes, or prostaglandin measurements. So in patients with severe asthma who may have kind of a mast cell phenotype, Gleevec has been shown to have some improvements. And again, this may be a potential target for severe refractory asthma. So, new things are on the horizon in terms of phenotyping and biomarkers for asthma. So this is where we are now in terms of, biologics for asthma, omalizumab, mepolizumab, Benra, and Dupixent. We have all of these available in the UAE. Reslizumab could potentially be available. That's an IV anti-IL-5 biologic. This is where we are now. But again, what you can see, unfortunately, is there is some overlap, right? So eosinophilia here, eosinophilia here, eosinophilia here. They all have an eosinophilic phenotype, but who would respond better to which medication? That kind of remains to be seen. So now what? You have your severe asthmatic, type 2 high. This is where we are now. Some medications are still in development. Tezepelumab, this will probably, anti-TSLP will probably get FDA approval in the next year. So what do we do? How do we decide which patient to put on what biologic? And that's what I'm going to talk, in the remaining time about a study that was recently done where they're trying to find, within same asthma phenotypes, what biomarkers, what patient characteristics can we use to properly identify who would be a better responder to a medication to help decrease the time needed to get optimal asthma control. So this was published 2 years ago in Allergy by Tom Casale and colleagues. And what they did was they wanted to look at factors that may predict response to Xolair because of the asthma heterogeneity. And they wanted to select patients who were most likely to derive the greatest clinical benefit from therapy. And that's all we want to do for our patients. A lot of these therapies are expensive. While they are safe, they do have side effects. We want to make sure the right patient gets the right treatment at the right time. And they have a good quote in their introduction. As newer biologic agents become available for asthma, which is where we are now, it will be important to understand the extent to which these agents compare with the existing therapies in the context of similar biomarkers and asthma severity. So what did they do? What was their study design? They took data from 2 pivotal phase 3 trials that were done earlier that were really important to get FDA regulatory approval for asthma. One of them was the Bill Bussey study that was done in 2001. And there was about 1,000 total patients. Both of those studies were similar. They had a 16-week ICS stable dose. Patients were on Xolair versus placebo, and then a 12-week ICS reduction dose. They were given Xolair or placebo based upon weight and IgE levels. And of those early studies, the primary endpoint was the number of asthma exacerbations, and they were defined 2 ways, either requirement for systemic steroids or doubling of the ICS dose. And so what they did is they took the data from those 2 studies and they examined them further. Since those trials were done 20 years ago, things have changed. Consensus recs have indicated that systemic steroids are required for severe exacerbation. Just because you increase ICS dose, double it, or even quadruple it, they don't consider that to be severe exacerbation. So in this study, they're looking at the number of exacerbations that required systemic steroids for 3 days or more. And they looked at the exacerbation rate with different cutoffs. Eosinophils less than 300, greater than 300. Eosinophils less than 200, less than 300, less than 400, greater than 400. Asthma severity, which they define as having an ER treatment or hospitalization in the year before enrollment. Cutoff FEV1 less than 65% predicted, greater than 65% predicted. How much inhaled corticosteroids were needed? Less than 600 mics of beclomethasone dipropionate, greater than 600 mics, and whether or not they were on a LABA. So again, over 500 patients, Xolair, 500 placebo, average age, again, roughly 40, 55% female, 20 years of asthma, average FEV1 65% predicted, average eosinophil counts 250, serum IgE about 150, etc. And so their primary endpoint was the rate of exacerbations requiring at least 3 days of systemic steroids. You had a relative rate reduction in this group of 55%. Now, this was actually more pronounced in patients that had a higher eosinophil count, more severe asthma history, lower lung function, higher ICS burden, and if they were using a LABA, and that's shown here. So reduction in exacerbation rate, patients that eat blood EOs less than 300, 45%, 67% in patients that had higher blood EOs. History of emergency asthma treatment, 33% no, 62% yes. Down the line, hospitalization, FEV1, ICS burden, and LABA use. Now, interestingly here, the higher the blood eosinophil count, the greater the reduction in the asthma exacerbation rate in this study. And that's shown anywhere here. You go from 100, 200, 300, up to 1,000. The higher your baseline blood eosinophil count was, you had a better response to omalizumab versus placebo. So significant findings. Again, omalizumab reduction in exacerbations was more pronounced in patients with increased asthma severity. Response to Xolair was seen across a wide range of blood eosinophils. They had no cutoff, unlike other studies that have been done. They looked at all the patients in their study. Of interest, the mechanism of action of Xolair is IgE, right? So it binds free serum IgE, precludes IgE from binding to the mast cells, and it also down-regulates the Fc epsilon receptor expression on mast cells. But interestingly, the higher the blood eosinophil count, they actually had a better response to Xolair. And so the findings suggest that patients with clinical markers of greater severity or higher baseline blood eosinophilia have a more pronounced reduction in severe exacerbations than patients that do not have these markers. So again, to wrap up, I know I covered a lot early in the morning. Current use of biomarkers to identify severe asthma phenotypes is limited. We do have readily available biomarkers to use, but unfortunately, none of these are really pathognomonic to diagnose one phenotype. Many biomarkers play multiple roles, and there is significant overlap. Now, if you look at biomarkers plus the clinical characteristics of a patient, together, these can be helpful, especially when you're looking at what biologic to start when. Newer biomarkers and therapeutics are still in development. And again, in the next year, we should have an anti-TSLP that gets FDA approval. And there are other agents that are in the pipeline. Ultimately, what we need, and again, this is why I said, bench to bedside, back to the bench. We really need data-backed algorithms to properly phenotype severe asthmatics to help individualize therapies and improve outcomes. We're much better off now than we were in 2010, better off in 2010 than we are in 2000. But again, I don't think the drug companies are going to do head-to-head clinical trials. So we need better, algorithms done from our societies to help guide us better. And that's really it. I have no further slides. It's up to you guys if we are going to take questions now, or if you want to take questions at the end, please let me know.
Thank you very much, Dr. Mohsen. That was a nice overview of severe asthma and phenotyping. I guess we can take a couple of questions now and then maybe defer the rest until the end of the session when more people are joining us. So before we go, let's start with, before we reach severe asthma, a lot of colleagues ask about asthma first presentation. Sometimes you can have an asthmatic present with an exacerbation. So you give them systemic steroid to control the exacerbation. But then the next question, what do I start treating those asthmatics? What helps you decide which agent to use as an initial treatment? What do you use? Patient's symptoms, or do you use the biomarkers that you mentioned to decide which step to start the treatment?
I use all. I'll use their comorbidities. Do they have rhinitis and sinusitis? Maybe they respond to something like Singulair. I use their FEV1. We will get, as an allergist, we skin test our patients. We'll use skin testing. I generally tend to start high and then wean down, because you want your patients to feel better and you want them to come back. But if they have an exacerbation, they receive steroids, they get discharged from the hospital, you don't want them to come back to the hospital. So I tend to overtreat and then wean down as you follow their symptoms, you follow their pheno, you follow their FEV1, you follow their ACT scores. But it's going to be comorbidities. What have they used before? They had an exacerbation. So what were they on? Were they only on an ICS? Were they on like a serotype discus they didn't know how to use? I mean, there's a lot of things that kind of go into the equation. I wish it was simple and there was just one simple answer.
Sure. So I will try and discuss this even more with you. Mm-hmm. I'll give you examples. If you read the guidelines, they are not very clear, especially with the early asthma or mild asthma of what to start with. So in the guideline, they say if somebody has symptoms once or less a month, mm-hmm. that's when you can use the PRN medication. Yeah. Yeah. If you have symptoms twice or more in a month, that's when you consider regular treatments such as low-dose ICS. Yes. Yep. And if you have symptoms, that's step 2, I guess we can call it. And if you have symptoms most of the days of the month, that's when you can consider, that's step 3 in the guideline, and that's when you start low-dose ICS LABA. Do you agree with this initial treatment strategy?
I do, but recently we've actually been putting even our intermittent asthmatics on a PRN Symbicort inhaler. So kind of using the SMART guidelines. I do think that the data is there. Patients tend to do better. But other than that, I think it does make sense, yes.
And we also have some questions about severe asthma. You mentioned the big trial at the end of your talk, the effect of omalizumab on the exacerbation rate, and the fact that the higher the eosinophil as a biomarker for severe asthmatics, mm-hmm. the higher the eosinophil, the higher the reduction in exacerbation. This sounds like other biologics, the new biologics, and this was not initially one of the discussions when omalizumab came out. What do you think about this analysis? How does it compare? Can you use eosinophil as you're using them with other biologics as a biomarker to reduce exacerbation?
Again, based upon the data in this trial, I think you actually can, and it makes sense, and it shows that the higher the eosinophil count, you're actually more likely to have a more robust response. I think in order to get regulatory approval for omalizumab, you have to have IgE and skin test positivity. But if you're on the fence for a patient that has eosinophils and may have IgE and they may be allergic, this shows that the higher the eosinophil count, you're going to have a more robust response with omalizumab. So I would use it in those patients, yes. You got muted, Dr. Ashraf.
I'm sorry about that. So you have severe asthmatics and you're happy they are uncontrolled and you've done your homework. How would you decide after you exhausted your maintenance treatment and you reach step 4 and now you want to go to consider biological treatment for this severe asthmatic. Tell me, in your real practice, what steps does Dr. Mohsen take to decide which biologic to give which patient? Do you have a simple table that you go through?
There's Busquet has published something showing that you kind of start with omalizumab, do it for 16 weeks. If they have a response, you continue. If not, you can go towards the other biologics. That's something that I've kind of tended to follow. If a patient will qualify for Xolair, I would probably start them with that. Now, there could be two reasons. Number one, it could be my bias as an allergist. And number two, we have much more real world evidence. We have safety data. It's safe. It's safer, or it's relatively safe in pregnancy. And so, I do tend to, follow Busquet and go with Xolair first. And then if they don't respond, we can kind of go to the others. However, if, for example, if they say they have chronic, bad chronic sinusitis and nasal polyps, and they've had 2 sinus surgeries before, maybe something like Dupixent that also has FDA and EMA approval for chronic sinusitis with nasal polyposis without asthma, that may be something you'd want to start as well. And then there's patient preference too. Does a patient want to get a medication that's injected every 2 weeks, every 4 weeks, every 8 weeks? If I have a patient that lives, in Ras Al Khaimah or Fujairah or Ajman, do they want to get a PCR test every 2 or 4 weeks? Wait an hour and a half at the border, come get injected. I mean, there's real world things as well. But Xolair kind of tends to be my go-to just because I have more personal experience with it. And maybe I have a referral bias as an allergist. More of my patients that get referred to me tend to be allergic versus maybe a pulmonologist may have other phenotypes that they're seeing.
Thank you. I think that's a nice way of looking at it. Thank you very much, Dr. Nasir. So thank you very much. And if we get more questions, I hope you're around by that time. I'd like to move on to our next speaker. Part of the Emirates Thoracic Society is thoracic surgery. And it's a big part that we look for every time we have a serious problem usually. And it's, I have to say, psychologically, I've always felt more comfortable when there is a thoracic surgeon around in the building whenever I'm about to do a procedure or get a scary CT scan results. Today, we have one of our active members at the Emirates Thoracic Society, Dr. James Aitchison from Al Ain, and he will talk to us over the next 40 minutes or so on the topic of lung cancer outcome and thoracic surgery. Dr. Aitchison, the floor is yours, and thank you for joining us today.
Okay, thank you very much for that kind introduction. Apologies if there's any problems with the network. I'm over in the UK at the moment, so it's quite some way for the distance. Anyway, here we go. So I'm going to talk about improving outcomes in lung cancer surgery, and thank you for the opportunity. So the whole aim of all of our surgical work, like everything else, is to achieve excellence. So we have a nucleus of a team. We've moved to SSMC now from Al Ain. So I work with Dr. Edward Black, who I'm sure you'll all be familiar with. We have a clinic outpatient nurse team, and we have a nurse coordinator, Zuleika Awad. So if you can't get in touch with us and you need any referrals, Zuleika is the person to go to for that. So the extent of the problem in terms of lung cancer, the latest data published from the USA said that over 200,000 people per year will be diagnosed with lung cancer, and 160,000 people per year in the USA died from lung cancer in 2017. Of these patients, 25 to 40% of the patients present with locally advanced disease, and most of the rest of these are not resectable. 29% of patients in the USA undergo surgical resection for lung cancer, and 90% of the 5-year survivors come from this group. However, 50% of those undergoing surgery die of residual lung cancer within 5 years. So how can we improve on this, and what outcomes are important? So I've broken this down into several areas. We've got early diagnosis. We've got survival, both perioperative and long-term. We've got time to return to preoperative levels of function, which includes length of hospital stay. We've got symptom control, and we've got psychological health. And how are we going to plan to improve lung cancer surgery? When you're setting up a new program in a big hospital, how are you going to do this? We looked at preoperative. How can you detect cancer? Can staging be done accurately and quickly? How can you accurately assess operability? That means, is the patient strong enough for it to be removed? And you can look at pre-optimization. How can you make the patient better to be able to tolerate the operation? Moving on, we looked at perioperative factors. So enhanced recovery is a big thing in Europe and the UK at the moment, and we're trying to get that set up here in the UAE. Regional and local anesthetic techniques are important for encouraging early function and minimizing pain. Minimal access surgery is a big thing, or a small thing, depending on which way you looked at. And lesser or extended resections for patients with greater tumors or lesser lung function. Postoperative factors, early mobilization, management of drainage have a big influence on that. And evidence-based post-op strategies. And finally, looking at the fact that 50% of our patients who have successful surgery will die from recurrence in the next 5 years, the role of neoadjuvant treatment or adjuvant treatments is important to prolong overall survival as well. So if we look at preoperative survival, how can we improve that? We need to find more cancers. We need to find the cancers when they're earlier stage and maybe asymptomatic. In terms of staging, we need more accurate assessment. Can we spot micrometastases, oligometastases that can be treated? And we need histological confirmation of the nodal status if all patients are operable or resectable. We need accurate assessment of the operability for these patients, including cardiac assessment and pulmonary assessment. CPEX is very important for that because it enables assessment of likely outcomes. And for patients who are borderline outcomes, prehabilitation is very important. Can you optimize the management of their comorbidities, cardiac disease, diabetes, bowel disease, liver disease? Can you make the patient fit enough for the surgery if they're not fit enough beforehand? And in the UK, we get lots of sedentary patients who are overweight and never walk further than the fridge or the car. So we want to make these people lose some weight, gain muscle strength, get themselves moving, cardiovascularly fit. And it's possible to do that within 6 weeks with aggressive programs. So back to the first of these, early detection of lung cancer and screening. So the USA recommends preventive screening for patients who have a heavy history of smoking and smoke now or have quit within the past 15 years and are aged between 55 and 80. So in 2011, the National Lung Screening Trial data was published in the New England Journal of Medicine. It's taken some time for that to filter through to practice changes. But if we look at this slide, we can see that the patients with the black line who had a low-dose CT scan compared to the red line, those who had plain chest x-rays, more lung cancers were shown in the first 2 to 3 years in those patients with an annual CT scan than an annual chest x-ray. And interestingly, you can see that that change persisted throughout the follow-up of the study, showing that more cancers were detected and it didn't result in simply earlier detection of cancers. More importantly, we can see that the deaths from lung cancer is a higher number in the patients who had chest x-rays and a lower number in those who had CTs. So the inference from this is that not only do you detect more cancers with the CT scan, but the management of those produces an all-cause and a lung cancer specific improvement in survival, which is great news. So evidence from Manchester, which is one of the worst areas for smoking-related disease in the UK, showed implementation of lung cancer screening. So people who'd smoked, aged between 55 and 74, were invited to lung health checks where CT scanners were positioned in local shopping centres, and people were able to walk in and arrange a CT scan and nursing assessment of their lung function and other functional status. And what they showed was that a significant number of patients had lung cancer. Of these with lung cancer, 80% were early stage, and of these identified patients, 65% had lung resection. And overall, 3% of the population who were screened had lung cancer. And so they found that taking a scanner to the patients, particularly in areas of urban deprivation, was a great way to increase diagnostic rates. So if we look at the NCCN guidelines for lung cancer, if we look at the early stage cancers, the recommendations for pre-treatment evaluation needs lung function, including DLCO if it's not normal and less than 75% predicted, or they've got other disease, bronchoscopy, pathological mediastinal lymph node evaluation, PET scan, and brain MRI, depending on the stage. Classification, if they've got negative mediastinal nodes, operable patients having surgical treatment, and we can go through that. Medically inoperable patients, definitive chemoradiation, or SBRT. Positive mediastinal nodes goes to a different group of patients who can have consideration of multimodality or trimodality treatments. So in terms of evaluation of the patients and fitness for surgery, the CHEST guidelines measure the FEV1 and a DLCO. If the percent postoperative predicted are both better than 60%, the patient is considered at low risk of anatomical resection. But if the postoperative predicted are less than 60%, we should do a low technology exercise test. And if that is not satisfactory, or the postoperative predicted are less than 30%, then a CPEX should be performed. For those patients with a postoperative predicted VO2 max of less than 10 mils per kilogram per minute, a high risk outcome and poor functional outcome with long-term disability is likely. However, if it's above 20, then there should be no problems at all. And they showed good evidence for making these recommendations. So what happens if your patient isn't fit and fails these criteria? So there's a nice meta-analysis of preoperative exercise intervention for patients awaiting resection for non-small cell lung cancer. So A is peak oxygen consumption, and we can show that the meta-analysis displayed an improvement in oxygen consumption with the fitness regimens. B is symptomatic shortness of breath, and symptomatic shortness of breath was improved with exercise prior to surgery. C looked at postoperative hospitalization, length of stay, and length of stay is shortened significantly by preoperative exercise regimen. And D, postoperative pulmonary complications is again significantly reduced. So all of these suggest that if our patients are not fit, rather than rushing into surgery or making a decision about non-surgical intervention, we should actually persuade them to undergo an exercise induction regimen. So we've looked at the preoperative improvement in outcomes. So how can we improve the perioperative outcomes? So we can look at enhanced recovery techniques. We can look at the use of regional and local anesthetic techniques. We can look at minimal access or robotic surgery. For patients who are borderline fitness for surgery, where the choice is surgery or another treatment, we can look at whether a lesser resection can be used. Can a sleeve resection be used for a patient to remove a tumor at the bifurcation of the left bronchus or the right upper lobe origin? Can a segmental resection be used for a small tumor in a patient who's got tumors bilaterally or has had previous resection? Extended resection might be appropriate for some patients with 3B disease, chest wall or Pancoast tumor, and locally advanced with N2 positive or a single metastasis can be treated successfully as well. So if we treat more of the patients, then we're going to get more of the patients in the group who have the best possible results. So there's a very nice paper published by my colleagues in England, Tim Batchelor, who we both know well, guidelines for enhanced recovery after lung surgery, and they went through an evidence-based list of techniques to improve this. I won't go through each one of the ones, but guidelines on preoperative fasting, about carbohydrate loading prior to surgery, recommendations for anesthetic techniques, antibiotics, avoiding hypothermia during surgery. They came to some well-evidenced surgical techniques. Intercostal, muscle and nerve sparing techniques are recommended. Methods for closing thoracotomy. Minimally invasive surgery with a high evidence level. Post-operative drain management. Minimizing urinary catheterization duration. Early mobilization. And here we have an example of that. So you can see the view intraoperatively of the local anesthetic infiltration to block the intercostal nerves at the end of the operation, so the patient will have local pain control without need for so much opiates. Thoracic epidural can be used. Paravertebral catheter usually has at least as good efficacy in terms of pain control as an epidural, but lower risk of complications and can be inserted by the surgeon under direct vision. A wound catheter can be placed in the intercostal space for pain control as well. Multiple intercostal blocks, as you can see, and borrowing from the skill of the anaesthetists, local field blocks, serratus blocks and erector spinae can provide improved pain control in the region. So moving on to surgical techniques, a thoracotomy is still required for some patients. And you can see pictures of standard thoracotomy from the American textbooks, although with the muscle sparing techniques, they're not normally as big as that. 3-port thoracoscopic approach. Here are some scars from a well-healed patient. Single port technique as promoted by Diego Gonzalez Rivas and others. And a robotic technique can be used. All of these, the aim is to minimize the amount of tissue damage and maximize the speed of recovery. So evidence of benefit for minimal access surgery. So VATS lobectomy is associated with shorter lengths of hospital stay, decreased morbidity and mortality compared with open approaches. A 50% reduction in complications compared to thoracotomy. A shorter length of stay, fewer complications, increased likelihood of independent discharge compared to open lobectomy for early stage lung cancer. So a lot of the concern was, if this is a harder thing to do through small holes, what is the effect on the overall disease-specific survival and the treatment of cancer. Well, actually, there was no difference in the long-term survival despite people's worries. And so this is one of the key points. In fact, survival is actually better, probably because of the decreased amount of trauma from a larger open operation compared to the thoracoscopic operation. So in terms of lesser resections, instead of performing a left pneumonectomy for this tumor, which is at the bifurcation of the left main bronchus into the upper lobe and lower lobe, a sleeve resection can be undertaken where the upper lobe is removed and the lower lobe bronchus and pulmonary artery are reanastomosed. So that's one of the procedures that we've performed at hospital here in Abu Dhabi. Segmental resection. These aren't my photographs, but they're available from a colleague on the web. We can see here is the segment 6 in the lower lobe. Here is the vein draining it, which can be taken. Here is the artery being taken to the same segment. Here is the bronchus being test clamped prior to stapling. And in order to find which area of the lung is included in the segment, after the bronchus has been stapled, the lung is reventilated, and this area you can see is not ventilated because of the bronchus being divided. So this area can be completely resected to make sure there's been an anatomical resection of that segment. So what's the evidence for when we should be doing lobectomy, segmentectomy, or wedge resection? And there's some fairly clear randomized trials from this. So the lobectomy lines are in blue, the segmentectomy lines are in green, and the wedge resection lines are in yellow or gold color. So we can see that there is no overall difference in survival for tumors that are less than 1 centimeter. And I would have to say that most surgeons would probably try to avoid a lobectomy if possible for a tumor that was less than 1 centimeter. And certainly there's good evidence base to justify that. For tumors that are between 1.1 and 2 centimeters, we can see that the wedge resection has a significantly impaired survival compared to both of the others. Less than 0.001 for lobectomy comparison, 0.004 for the segmentectomy comparison. But the segmentectomy has a non-significant difference between lobectomy and segment for these tumors. And for those tumors that are over 2 centimeters, we can see that the survival is worse for both the lesser resections and the lobectomy. So when would we consider doing a segmentectomy for these patients? Well, the answer is when they've got multiple tumors, bilateral tumors, or when they've had previous surgery, or when their lung resection is for a patient with markedly impaired lung function. We can talk about evidence for SBRT for small early stage tumors and segmentectomy. But of course, with SBRT, you cannot guarantee complete destruction of the tumor. The survival may be similar, but the one thing with surgery is that you can remove it. So how do we improve post-operative outcomes? Regional and local anesthetic techniques, you saw some of the pictures of the things. We can put catheters in to give regional pain control. We have catheters that no longer require pumps, that have an elastomer-filled bottle that contracts, and these the patient can put in their dressing gown pocket and carry on walking around with the infusion. Ambulatory management, so getting the patient up on the first morning of surgery. Digital drainage systems such as Topaz. Miniature drainage devices that the patient can mobilize easily with and even go home. Following up, evidence base. So here's the digital drainage devices. This is the one that we're using in SSMC and have been using in Taiwan before. They display how much of a leak of air. So you can see if the air leak is coming down. You can see how much fluid has drained in the last hour, the last 6 hours, the last 24 hours. So this means that if we can see that the air leak has stopped and there's been no air leak for 12 hours, we can take the drain out. We don't have to rely on observations from the nurses or the junior doctors doing rounds. And it also means that the suction can be provided and the patient can walk around mobilizing, carrying this fairly light device rather than being plugged into the wall. There is evidence that these make a significant difference. So the Topaz drainage system is recommended by the UK called NICE, and this can show the duration of chest tube drainage and length of stay are both reduced. Sounds good, but this is expensive, and it took us some time to get that through the cost panel at SSMC. But actually you can show that you save money with this, because the disposables are cheaper than the other things and you save time. Wearable drainage systems. So instead of having a great big bottle connected to the wall, the patient can have a small device which effectively lets the air out and has a small reservoir capacity for a bit of drainage. So follow-up. How do we see our patients? Do we see our patients? Do we hand them back to the chest physicians? Should we take chest x-rays? Should we do an annual CT scan? So what is the evidence for this? So the amount of evidence is relatively small on this, but there are some firm recommendations which are evidence-based. And the NCCN guidelines, which are the ones that we follow, are the patient should be seen 6 monthly for 2 years, then annually. They should have history, clinical examination, and CT scan at appropriate points, and at least annually for the first few years. So we've covered the care of the patient preoperatively, operatively, postoperatively, and in terms of follow-up. But what does the patient consider as the most important thing? And they want to have excellent care. And it's all very well us offering a perfect operation, but if there's difficulty in accessing this or they're unsure about things, how are we going to improve all of that? So the addition of lung cancer clinical nurse specialists was something that was instituted in the UK a few years ago, and we're developing now. But a nurse link point increases service access. A nurse providing reassurance and as a link point, if there's any problems, can get patients back into the service to hopefully minimize mortality and prevent morbidity. They can help the patients with their symptom management and understand how to look after themselves. They can help for that large proportion of the patients who unfortunately have cancer recur, and they are significantly improving patient experience and satisfaction. And of course, in this current day of age, cost effectiveness and efficiency. If our nurses will reduce the demands of the patients on other healthcare services and focus the care appropriately, they're both efficient and cost effective. And finally, in terms of our long-term follow-up, what's the evidence base for neoadjuvant and adjuvant treatment? Because if half of our patients will get recurrence, then how can we minimize that? Of course, those patients with confirmed stage 3A or extended resections for chest wall or pancoast should have neoadjuvant treatment. If it's a smaller primary that is confirmed histologically to be 3A with N2 disease subsequently, then they clearly need adjuvant treatment. If it's an intraoperative finding of N2 disease, and if the margins taken were smaller in borderline patients, then clearly adjuvant treatment is recommended. So that brings me to the conclusion for my talk today, but I'm happy to take questions from the floor.
Thank you very much, Dr. Aitchison. That was a great overview, and I have tons of questions for you. First of all, maybe a pessimistic view. I hope you can make me more hopeful. I remember when I did my thoracic surgery, that was around 2004, the outcome of lung cancer was 50% at 5 years. And I hear you quoting the same percentage, 50% die at 5 years. Why do you think that is?
I think ultimately, like a lot of cancers, we have a population who have a high risk of cancer recurrence and cancers that have already spread, despite our best efforts to identify them. And I think that's where we need to know now what sort of cancer type it is and the genotype of the cancer to enable specific forms of treatment, such as the EGFR and the other PDL markers and things. And maybe these patients should have immunotherapy after surgery, as opposed to wait until they have a recurrence and then reassess.
You mentioned, Dr. Aitchison, that the CT screen lowered the death.
Yes, that's right.
So are you advocating for CT screening in UAE? How do you want to do that?
Yes, so there are 2 points here in terms of detecting cancer earlier. The first point is in looking at patients who have early cancer and some symptoms who are currently not accessing. They need quicker access to testing, and we're trying to set that up at the moment. And the second part is the actual screening of patients who are at risk, who smoke, who have no symptoms. And yes, there is a strong evidence-based recommendation for that in the UK and the USA, and a lot of the HMOs are providing that now in both the UK and the USA. So I think that's something that could be developed. I know it's available at Cleveland Clinic, but the other Seha hospitals are not able to offer screening at the moment.
Fair enough. I have a question for Dr. Mohsen Nasir, if he's still with us. Dr. Mohsen?
Yeah, I'm here.
Dr. Mohsen, I have a question from one of our interventionalists, Dr. Trilak from Burjeel. He's asking you about the choice of biologics in pregnant ladies, depending on their eosinophil. What if their IgE is high and their eosinophil count is high? Which one would you choose for a pregnant lady, and why?
So I would choose Xolair for sure. I mean, we have the data from the EXCELS trial showing that it's safe in pregnancy, it's efficacious, it's FDA category B in pregnancy, which for all intents and purposes is kind of the best one that we have. However, if let's just say this patient was purely eosinophilic and they did not have IgE and they were not allergic, as we know, taking care of these severe asthmatics, there are significant negative consequences to the fetus if a patient has if a pregnant woman has uncontrolled asthma, either from high dose of steroids, small for gestational age, gestational diabetes, and fetal termination. I've seen with severe asthma in pregnancy in some inner-city African American women's. So I would use the other biologics. That's all that we have to control their asthma. Because again, you want to save the mother's life, you want to save the baby's life, you want to do it as safe as possible. And even if you don't have the data for the other biologics that we do with Xolair, I would still use them.
Thank you. Dr. Aitchison, lobectomy, segmentectomy, wedge resection. Is it really the size of the tumor, or is it the practice of the country? I've seen a lot of our patients come abroad. As you know, UAE send a lot of patients abroad. They go to Korea, they're big fans of segmentectomy as opposed to wedge and lobectomy. Is this a practice and comfort, or is it really the size of the tumor and the functionality of how functional the patient is?
It should be related to the patient and their tumor rather than where you send them. So there are some skill implications with it, in that the survival benefit probably represents the removal of the lymph node drainage pattern of the tumor. But with the segmentectomy, you're not going to get removal of the entire lymph node drainage pattern for that region. That's going to be more likely with a lobectomy. So the question is, if you have somebody who's fit and well and it's their first cancer and they've got no other problems and they've got a 1 to 2 centimeter tumor, then would you rather have a segment or a lobectomy? So the evidence in terms of function is no different for a fit patient in terms of reducing their lung volume. So you're better to just take the lobe out if you can, because you get a better enhanced drainage. And certainly the curves are not inferior for a lobectomy versus a segment. If you've got tumors in other lobes, then that's an interesting point. And then the question is, if you've done a lobectomy on the left, how easy is it to do a further lobectomy on the right? And that becomes a problem. And if it's a recurrent tumor, again, how much lung function is left? Where is the tumor? But if you've got a single 1 centimeter tumor or a 1.1 centimeter tumor, and it's readily accessible with a segment, then that may well be worth doing.
Fair enough.
I can see Dr. Black is asking a question now.
I don't know how Dr. Black get into the room. Obviously, he's a big IT guy. He sneaked into the room, and I see his video and raising hand, so I was actually raising my hand back to him.
Yeah.
So, Dr. Black, you're welcome to join us if you have any comment on this topic or other topics of Dr. Aitchison.
Dr. Aitchison, sorry, good morning. Good morning. So Dr. Aitchison slipped in a comment that needs a bit of further emphasis, I feel. And this is a touchy subject, particularly in this country, and that is quality of surgery. Now, what do I mean by that? So over the last 30 years in the UK, there has been progressive understanding that lobectomy, what is considered a standard operation, is not always done properly. It requires actually individual division and separation of the bronchus, the lymph nodes, the veins and the arteries, and proper mediastinal lymph node dissection. And it's taken years to do that, even with open techniques. The problems with it relate to the topic that we don't like to talk about in surgery, and that is that, unlike, say, in a medical discipline, surgery requires a skill, and not everybody is equal. And that's a truth that we don't like to talk about. And this is very important in minimal access surgery, because the skill required to do a segmentectomy with equivalent outcomes to lobectomy require two things. One, suitable anatomy of the lesion in where it is located in the lung, and suitable skill of the surgeon and his or her team. It's not an easy operation unless you're talking about a lingulectomy. It's not easy. And unfortunately, not all operation notes and data that's entered into these trials is actually screened for quality, because how do you do that? How do you blind and remove bias when the surgeon is self-reporting their own quality? But this is a fundamental problem that we have with looking at comparisons between wedge, segment, lobe, as well as distance of the lesion, smallest distance to the margin. This is the quality of the surgery. It's very important. And of course, it's very emotive and unfortunately difficult to make it pure black and white, say you would in a randomized trial. And in clinical practice, it's very difficult to control. I think this is fundamental. The other point I wanted to emphasize from Dr. Aitchison's, he commented on this, we should be prescribing and treating patients with immunotherapies and other biologics based on the original histology, not waiting for recurrent disease. I think this is now being supported with evidence. I'm not 100% sure on that, and I wondered what your comments were. I think there's just recently been some data on this.
Sure. Thank you very much, Dr. Black. Dr. Aitchison, do you want to comment on Dr. Black's suggestions, or you're happy?
No, I'm very grateful for my greatly appreciated colleagues' comments. It's a question of making sure that we do the right thing and that everybody knows it's the right thing. That's the important thing.
Sure. I have two more questions for the surgeons while you're around. The first one is the VO max. Do you actually measure VO max physically at SSMC or in or Dr. Black in Al-Ain pre-op, and when do you need to do that? I'll start with Dr. Aitchison.
We don't actually have access to that at the moment, and that's one of the things that we are working on, but it is available at the Cleveland Clinic. So when it has been helpful, we have sent some patients to the Cleveland Clinic to get their assessments done. But it does require complex skills of technicians and the machinery to do it.
Yes, sir. Dr. Black? And the other question I wanted also
from me is, sorry, I just waited for the unmute. Sorry, yes, I'm actually in SSMC these days and normally running the service. So VO2 max is nice because you can standardize your data with colleagues around the world. But in fact, if a patient can walk up 2 flights of stairs while maintaining a conversation, they don't need anything more. But for legal reasons, we always do lung function. But actually, if they can walk up and down 2 flights of stairs whilst giving you their history, it's enough. So VO2 max is nice if a patient can't do an exercise, the ECG, do lung function, or a dobutamine stress echo if they've got, say, arthritis or they're wheelchair bound for another reason. It's a useful adjunct, and as Dr. Aitchison said, in SSMC we are going to be getting it soon. It's more useful for my esophageal patients, I find, actually, than the lungs.
Okay, thank you very much. And the last question for the thoracic surgery is on the TOPAZ. Is that how you pronounce it? The TOPAZ for the. Can you use this for chest drains without surgery? I mean, somebody who has bronchopleural fistula or a pneumothorax, and instead of putting the regular drain, you'd like to put this instrument to check if the leak has sealed or not? Or do you only use it post-operatively?
No, it can be used for non-operative patients as well, particularly those with air leak. And it's very helpful for that, particularly the patients with secondary pneumothorax with emphysema, because the amount of suction is very accurately controlled by the machine, and the patient is not confined to bed or the chair with a tube plugged into the wall. So they're able to walk to the bathroom, we're able to mobilize them, we're able to get them actually doing some physical exercises, walk up and down the corridor, go on an exercise bike, and all of this improves both their health and the resolution of the pneumothorax.
I think it's great. I have to excuse my ignorance, but I haven't seen or heard about the TOPAZ before. I think it's a great instrument, it looks like, because that's always a question, like when you go to the patient's bedside and you ask them to cough and see if the fistula has sealed or not. So it'd be nice to have another instrument to help you beside your clinical judgment, of course. We're finished with our questions, and I would probably give myself a permission to ask you, since you're in the UK, to give us a couple of minutes about how is COVID-19 in the UK? Which part are you at, and what's going on there?
So I'm in Essex, just outside London to the east. So it's it's changing rapidly here, and like the UAE, we're having different plans every day and a different announcement. So we're in an interesting period where everybody is saying everything's being done wrongly. There's not a huge amount of evidence about management of the economics of it and the social part of it. While the numbers in the UK are similar to what we saw in April, we're looking at something very different. In April, the only people who were tested were those who were admitted to hospital with respiratory symptoms. If you had respiratory symptoms and did not need to go to hospital, you were told to stay home and isolate. So only people who were admitted were counted. Now we're in a situation that people who work in key employment such as education, healthcare, government are being tested if their children have a cough or a sniffle. So we're looking at a very different population, and most of the positive tests are coming in asymptomatic people. And the numbers of tests that are done are over 100,000 a day, up to 200,000 a day. So practically 1 million tests a week. So from that point of view, we're picking up as many cases as were diagnosed. But the hospitals, my local hospitals in the UK, there's a network of 4 where I used to work. And there's currently 3 patients, 1 ventilated on an ITU and 2 patients not. Whereas in March and April, the whole hospitals were full. My cardiothoracic unit here was closed, was full only of ventilated COVID patients. So while the numbers are being seen as higher than before, we're looking at a very different population base. And I think hopefully that's going to reduce. And if you look at the curves from the UK, you will see that the mortality is very low. The numbers had been less than 50 patients a week dying, whereas the patients dying had been 1,000 a day earlier at the peak. So I think we're a lot better than we were, but there's a lot of concern.
So similarity and difference, I would say, the similarity to UAE is the fact that a lot of cases back, there is a surge like in April, however, they are not as severe. That's the similarity between the UAE and the UK, I guess. The difference is actually the type of population that's been screened. You're saying that in the UK, you're now screening everybody, but in UAE, since day one, they're screening, we are screening everybody. So that led some of the expert thinking that because the numbers are going high, but the severity is definitely not the same. An audit from our radiology department tell us that back in April, out of 100 CT scan, 97 CT scans will show COVID pneumonia. Now, out of 20, this week we did an audit, only 3 CT scans showed pneumonia. So is it a mutation in the gene? Some experts are saying there have been documented mutations in the gene that has led to a surge, but less severe of COVID cases.
Interesting. I just put my microphone back on. That's interesting. The UK, because the numbers of cases being tested was only those admitted to hospital with respiratory disease, the perceived mortality was thought to be very high. But when we actually looked at the prevalence in July in London, 17% of the population had antibodies, and about half of the population who have been exposed to the virus developed antibodies, or at least were responding on those early tests to having shown antibodies. So probably up to 30% of the people had been exposed, in which case the mortality rates were what you would expect and were less than 1% overall in the UK. But if you don't know what the prevalence was, it's very difficult to work out what the correct case fatality rate is.
Did you say 70 or 17?
17. That was what had antibody tests in the first series of antibody prevalence tests in July in the UK.
I can share with you a similar number in the UAE vaccine trial. And I'm not actually part of the trial to speak about it, but I had a conversation with those who are conducting the trial. And from the recruits for the trial, it seems like the prevalence of antibodies for people was 10% in UAE. So it's a bit lower. So it seems like you have a higher prevalence, although this was not a study for the prevalence of the antibody, it was recruiting people for the vaccine trial. That's pretty interesting. Do I have any comments from our colleagues, Dr. Mohsen or Dr. Black?
No, no comments on my end.
Thank you. Thank you very much. Thank you very much, all of you. It's been a pleasure having you. Are you planning for a nice British orange marmalade now for breakfast with the young lady behind your back?
I've had an early breakfast already, actually. Thank you.
Okay.
So yes.
I will see you, inshallah, soon in UAE, in Abu Dhabi. I'd like to thank Novartis for their kind sponsorship and continued support of the Emirates Thoracic Society. I'm very grateful for my speakers for their valuable input and contribution. And I'd like to thank MCO for their beautiful organization and communication to have this meeting at this nice time of the day. I wish you all a very happy weekend, and inshallah wish to see you all next time in our ETS meetings. Assalamu alaikum.
Thank you, everybody.
Stay safe. Have a good weekend.
Thank you, doctors.